Hi everybody, my name is Tyler Letellier, and for my assignment I chose this study, and the title of that is called Early versus Standard Tracheostomy in Ventilated Patients in the Neurosurgical Intensive Care Unit. So for introduction, this study focuses on primarily neurological ICU patients with the tracheostomy requiring prolonged ventilation. And it asks the question, does early tracheostomy in mechanical ventilated patients in the neuro ICU associate with a shorter amount of time on a ventilator compared to the patients that received a standard tracheostomy? At the time of this study, there was no general consensus really for optimal timing in performing a tracheostomy on this type of patient population. So a little background about the study. This was a random controlled trial, and this took place from 2019 to 2021. It was published in 2022 in the Journal of Clinical Neuroscience, and this was a single-centered study, meaning that this only took place at one place, one hospital, specifically at the University Malaya Medical Center in Kuala Lumpur, Malaysia. It was authored by two authors, Gu and Arasu. So were there any conflict of interest in this study? The authors, both of them worked at the Department of Surgery at the same hospital where the study was conducted. Both declared that they had no competing financial interest or personal relationships that could influence the outcomes. In the study, there was no financial support mentioned, as this study was conducted again at the same hospital where the authors were employed. Due to the fact that there is no funding mentioned, it's unlikely for the authors to have any financial gain from their findings. Therefore, conflict of interest is unlikely. So the hypothesis of this study takes a look at early versus standard tracheostomy placement in patients requiring mechanical ventilation to see if the early trach patients have a shorter duration on mechanical ventilation versus the standard. The authors, both of them, predicted that early trach patients could lead to a shorter amount of time on the ventilator, based on some studies that favor early tracheostomy and other limited studies that are out there that explore the benefits of early tracheostomy in patients with a neurological specific type of injury. The study population in this study consisted of adult patients receiving a tracheotomy with prolonged mechanical ventilation who suffered a catastrophic neurological insult or upper airway obstruction. The inclusion criteria were patients that were screened by a neurological intensivist admitted to the neurosurgical ICU that likely requires prolonged mechanical ventilation. The exclusion criteria were patients with no chance of survival, cardiac arrest on arrival, on blood thinners that are sufficient to contraindicate a tracheotomy, and patients requiring immediate tracheostomy, and of course patients who were extubated before a tracheostomy. So a power analysis was performed in this study with a stated power of 80%. The minimal sample size to meet the stated power was approximately 34 patients. The actual final sample size was 39 patients total, 20 in the early group and 19 in the standard. This study was adequately powered, 39 total patients, which is 5 more than a minimum of a patient size of 34. So we have our 39 patients, and how were they allocated? This was determined by stratified randomization. Patients were randomized into a 1-to-1 ratio, earlier standard trach groups. 20 patients in the early group, which we call the treatment group, and 19 patients in the standard group, the control group. So how were the patients randomized? The patients were randomized into a 1-to-1 group. The stratification was the type of neurological insult, traumatic brain injury, or spontaneous intracranial bleeding. Details of the allocated group were prepared in a sequentially numbered and sealed envelopes. To enroll a patient into the study, the clinician opened the next consecutively numbered envelope, Patients who were randomized to the early trach group had the trach performed 7 days before mechanical ventilation, while the standard group had the trach performed on or after 7 days of mechanical ventilation. Confounding variables. There wasn't a whole lot of confounding variables in this study. However, some things I'd like to point out: both control and treatment groups were mostly male with very little female participants. And another thing that really wasn't mentioned is there was no mention on ventilator settings prior to their tracheotomy procedure, which could potentially have an effect on the duration of days requiring mechanical ventilation. This study was unable to blind the subject and surgeons due to the nature of the study. From a researcher's point of view, the statistician was blinded to reduce biases. In terms of bedside clinicians, they were blinded until the tracheostomy was placed. Therefore, the study overall was unblinded. Once the patients received a trach, it was then known what intervention was used. This did not affect the outcomes. However, once the trach procedure was completed, before 7 or after 7 days, it was telling who was in what group. Therefore, it is plausible to think that clinicians may have put a stronger emphasis on ventilator weaning methods on their early trach group, which could affect outcomes. The primary result that was measured in this study was the number of days on mechanical ventilation after a trach was placed, early versus standard, while in the neurosurgical intensive care unit. The secondary outcomes measured were the number of days on mechanical ventilation before tracheostomy, the number of days in the neurosurgical ICU after a tracheostomy, the number of days in the hospital after a trach, and any trach complications. So, was the primary and secondary outcomes appropriate? Why, yes, they were. The study was well designed and allowed the researchers to answer their question if early tracheostomy reduces the number of days on mechanical ventilation. And this, again, was achieved by measuring the number of days on a ventilator post-trach placement. For accuracy and precision of this study, even though it really wasn't mentioned within the literature, the data collected prior to being analyzed was most likely taken from medical records. This includes various things, including gender, age, weight, body mass index, Glasgow Coma score, also any kind of neurological, radiological findings in trach complications. Now, due to the simplicity of the study, it's easy to conclude that the collected data was accurate. And this is either by observation, medical chart review, simple by counting the number of days requiring mechanical ventilation after a trach was placed. It would be extremely difficult to have skewed results. So at the end of the study, once it was completed, here's some numbers. We started with a sample size of 39 patients, and we ended with 39 patients. Originally, there were a total of 42 patients, but 3 patients refused a trach, and therefore they were excluded from the study. Therefore, the main sample size was reduced to 39, which remained constant throughout the process. All 39 patients completed the study. Was this study per protocol or intention to treat? As quoted, all patients were analyzed based on intention to treat analysis. This was by Gu. Since the study started with 39 patients and ended with 39, there was no reported missing data as all patients completed the study. So the reported results of this study, they showed the primary outcome, which is the mean days of mechanical ventilation post-trach, was statistically different in 2 groups, with the early being 11.9 and the standard 18.9 days with a power of 0.014. Therefore, the early trach group had the better outcome in terms of days of mechanical ventilation post-trach, was 11.9 days. This is statistically significant because the p-value is 0.014, which is less than 0.05, which means that the null hypothesis should be rejected. Now, the secondary outcome, which is the days of neurosurgical intensive care unit admission post-trach, really wasn't statistically different in both groups, the early and standard, being early 20 days and standard 23.5, with the power of 0.307. Again, the early group had a better outcome compared to the secondary, being 20 days. The secondary outcome is not statistically significant due to the p-value of 0.307, which is greater than 0.05 and indicates strong evidence for the null hypothesis. In terms of subgroups, there were no subgroups in this study. So what did the authors conclude in this study? Well, they concluded that early tracheostomy is, in fact, associated with a shorter duration for the need of a patient being on mechanical ventilation in the neurosurgical intensive care unit. In addition, they also concluded that there could be a special relevance during the COVID-19 pandemic, as early trach patients in selected patients could alleviate the ICU strain. This study was pretty straightforward. The power of the study, the sample size, they were all appropriate. The outcomes were solid, and it leaves no question about it if there was enough sufficient evidence or not. The author's goal was to discern the amount of time a patient was on a ventilator after a tracheostomy. It would be very difficult to have any variability in the outcomes. However, I would take this study with a grain of salt because this was, remembered, a single-centered study. I believe a multi-centered study would have been better for the generability of the findings. Also, the long-term neurological outcomes was really not available in this study. In terms of harms and interactions, the authors of the study provided no harms or interactions that occurred throughout the study. However, they did report that there was a slight increase in ventilator-associated pneumonia, or VAP, in the early trach group, and that was found in the table, which is in the previous slide. But overall was considered not statistically significant. So based on the conclusions and fact-finding in the tables, the benefits are greater than the risks. Early trach patients can be weaned off a ventilator in a shorter time period. This implies that a shorter number of days in the ICU, which is, in the larger sense, cost saving, and ultimately a shorter length of stay within the hospital. With shorter ICU days, there is potential to help other patients in need of ICU care. Personally, I would have no issue with implementing this study at my work, and in some cases, we are kind of already doing this. So what about the cost of this study? As a clinician interested in implementing the outcome of this study, I would have to ask what the overhead costs and potential savings are. Both groups are receiving a tracheostomy, which the cost of the procedure is the same presumably. But the question that remains unanswered within this study was what type of procedure was used. Trach patients typically get it placed by a surgical or a percutaneous placement. According to one study, Bahari et al. 2018, the authors had originally believed, based on previous data, that a percutaneous trach is more cost-effective and has fewer complications when compared to a surgical tracheostomy. However, based on the findings, there was no discernible difference in the costs and outcomes. Granted, this study is a few years older, it would be worth taking a closer look before implementing to better understand costs with the goals to save money. In terms of length of stay and ICU costs, patients with early tracheostomies were around $4,316 less when compared to patients with late tracheostomy, and that is from Harrod et al. 2018. Overall, the early tracheostomy group saves money. Therefore, the results of this study promotes early tracheostomy, which is, in effect, cost saving. So the results of this study, according to the tables, would more than likely impact my decision as a clinician because of the differences of days after a tracheostomy, the number of days in the ICU after a trach, and the number of days of hospital admission after a trach. They all point to favor the early trach group with less days overall. As a clinician, this means that less days on the ventilator, in the ICU, and the hospital is all beneficial for the patient and the hospital. Harrod et al. 2018. As overall, it reduces ICU and hospital costs and ventilator-dependent days. Overall, the authors did a great job at not deviating from their original hypothesis, and were very careful not to extrapolate from other populations through the screening process. However, the authors did state, quote, during the current COVID-19 pandemic caused by the novel coronavirus, SARS-CoV-2, there are shortages of ventilators and intensive care unit ICU beds. By Gu and Muthusamy, 2022, page 165. Also, quote, a few studies suggested that early tracheostomy in carefully selected patients could alleviate the ICU capacity strain. Our study showed that early tracheostomy could potentially aid in combating the COVID-19 pandemic. Gu and Muthusamy, 2022, page 165. The authors did conclude that there may be some relevance during the COVID-19 pandemic, as early trach patients could alleviate ICU strain. It should be noted that this study did take place during the pandemic, and results could potentially be different pre- and post-pandemic due to lack of equipment and staffing shortages. However, the authors stayed true to the study for the given time period and did not question anything else but the raw data analysis that was received. So in conclusion, the researchers were able to prove their hypothesis by proving that early tracheostomy is, in fact, associated with a shorter duration of mechanical ventilation while in the neurosurgical ICU. Objectively, this led to lower total patient costs from $2,000 to $52,173 UDG per patient. Gu and Muthusamy, 2022. That's the end of my presentation, and lastly, here are the references for you guys. Thank you very much.